Thank you very much. Thank you, Mr. Chairman. I'd like to thank Professor Amjad and the organizing committee for inviting me in this session. We will move from the very new subject, COVID and nephrology, to very old subject, a common subject, urinary tract infection. I guess any doctors in his clinic will come across to the urinary tract infection cases. So basically, it's an old subject, difficult to find the slides updated, but I did my own slides. I hope you will bear that with me. If we have the UTIs, are they same in one group? Or we should classify them to different groups? And what is the impact on our treatment for the urinary tract infection if we're going to classify them? The old classification, it's either upper urinary tract infection involving the kidneys or the lower urinary tract infection involving the lower urinary tract. In my talk, because of the time constraint, I will concentrate on the bladders and the kidneys because it's a huge subject when involved the other urological infections. The many international bodies try to put classifications for the urinary tract infections, and they depend on many factors like the presentation, the severity, the anatomical location, the risk factors, and the resistance of the microorganism. And they depend on Ornick's classification, with basically O is no risk, R is recurrent urinary tract infection, E is extra urogenital risk factors, or N is nephropathic, presence or absence of any urological abnormalities, whether it's transient or permanent. So the very common classifications that's being used in the literature these days, it's the concept of uncomplicated and complicated, which has been adopted by the European Association of Urology. Basically, the uncomplicated, it's either in the bladder or in the kidneys. It can be recurrent. While the complicated, it can also, in the both bladder and the kidneys, it can be recurrent. And complicated UTI involving the man and cannot be uncomplicated. And both of them can be risks for developing urosepsis. So this is for the sake of the discussion, a quick discussion in this session, I involved one category which is embedded in the not complicated or even complicated urinary tract infection, and we call it asymptomatic bacteriuria, which commonly we face in our clinic, in our practices. Patients come to you with a positive culture, but he's or she's asymptomatic. What should we do with this? We'll go through all these categories quickly. Asymptomatic bacteriuria, it's common in young as well as in old women. It can be seen in a very elderly, institutionalized with severe comorbidities like spinal cord injury. As we said, there is no symptoms, but the culture is only positive. So if the patient is asymptomatic, should we treat this patient or not? She or me or he may say, sorry, I have no symptoms. Why should you treat me? It's a valid question. So here in this, all the studies, they try to see what is the consequences if we group the patients for treated with antibiotic according to the culture and sensitivity, and those patients not treated. The red one is not treated, and the green one, as you say, is treated woman. And here, after 12 months, if you see the not treated women, they are better off because the recurrence of UTI it will be much, much less. In comparison, which is almost nearly 50% for those patients we treated them. And after 1 year, they will have history of recurrence. And we will come back, I will come later to the recurrence UTI. And if we extend the follow-up for about 3 years, same patients which been treated, and we see here, after 3 years, we will say high incidence of the green. The green is the treated people or the women. They are not free from recurrence. They have higher recurrence rate. There is special categories I'd like to mention here about asymptomatic bacteriuria. It's in pregnancy, and probably other categories for those patients pre-surgery, urological surgery. As pregnancy or the asymptomatic bacteriuria in pregnancy is the same like other ABUs, like what we saw earlier. And what are the consequences? Especially, we're talking about maternal consequences and neonatal consequences. Should we treat ABUI in pregnancy or not? This study, it's very hard to find really updated study about pregnancy and antibiotics. It's not easy to make trials in a pregnant woman. They will not accept that. But in the literature, I found probably one of the recent one is 2015, where the prospective cohort study studying the maternal and neonatal consequences to treated and to non-treated women. Maybe forgive me about this slide, it's a bit busy, but let us concentrate on the small box up, the upper box. And you will see the complication like pyelonephritis. It's more common than in untreated patient, as well as the premature deliveries, less than 34 weeks of gestation. Of course, you will see that other complications like pregnancy-induced hypertension and urinary tract infection after the post-mortem, they are more in untreated patients. The neonatal, we will find preterm more common amongst the untreated patients, as well as the small for gestation. It's more significantly higher in untreated than treated women. So the second group of patients we'd like to focus on are those who will be subjected prior to surgery, urological surgery, including the cystoscopy or TURPs or whatsoever. There is a disruptions or breachings of the mucosal lining. And here, there is an old study as well, studying 192 patients, and all of them, they have asymptomatic, they've been treated with antibiotic, and the others, they are not treated with antibiotics. And they divided to two groups. The treated groups, preoperatively, 40%, while the untreated group is, the treated group is 43%. They found asymptomatic bacteriuria, while the untreated groups, again, they are 40% pre-op. Post-op, the asymptomatic bacteriuria was 42%, and they found reduction of bacteriuria in those treated. And during the 6 weeks post-op, there was no complication of those people which were treated pre-op, while there is complications of acute pyelonephritis and even sometimes septicemia in patients who are not treated. So basically, is it beneficial to treat asymptomatic bacteriuria? The clear answer, the big answer is no. We should not treat patients with asymptomatic bacteriuria in a young woman with no risk factors. We should not have this reactive attitude. We treat the paper rather than we treat the patient. Okay? And if a patient, even with comorbidities like kidney transplant or like diabetes, even if he's elderly, hospitalized patient, we should not treat if he's asymptomatic. But we should treat a patient with asymptomatic bacteriuria in a young pregnant woman because it carries beneficial effect on the maternal and the neonatal side. Prior to surgery, it's advisable to treat asymptomatic bacteriuria. Now, we will go to the subject with uncomplicated bacteriuria, which is either it's in the bladder, cystitis, or later on we'll discuss the pyelonephritis when it is upper urinary tract infection. It can be acute, it can be sporadic, it can be recurrent, and because it's uncomplicated, not a pregnant woman, and without any abnormalities. Usually it is localized symptoms like pain, lower abdominal pain, urgency, frequency, but not systematic manifestation like chills, fever, rigors, loss of appetite, and cultures is positive. It's very common, especially among the women. It can affect about 1/3 of women who are below 24 years of age, and half of all the women at any given age, they will experience at least one time in their life UTI. Usually the patient for uncomplicated cystitis, it's young, sexually active. She might have a past history of UTI, or she might have a family history that her mother had UTI. The commonest organism still is the E. coli, which consists about 70 or above 77%. And how we treat these people. Usually we used to give trimethoprim and sulfamethoxazole, and this is an old treatment, but unfortunately a lot of resistance emerged. So in the last 2 decades, they tried to find another solution, which is nitrofurantoin, a short course. And here is about 160 patients were included for nitrofurantoin, and 148 patients were included for Bactrim or Septrin. And we found the efficacy of both drugs are very effective. So even in the presence of non-susceptible or resistance to Bactrim or Septrin. Another drugs, because even a lot of resistance emerged for nitrofurantoin, we have a sort of a reactive attitude, straight ciprofloxacin. Why? Yes, it is effective, but we can see now a lot of patients come with resistance to ciprofloxacin. Another drugs, it's available there in the market. Unfortunately, in Bahrain, just recently came. This is very old drug. I'm sure my colleagues from the other part of the Arab world, Egypt, maybe even Saudi Arabia or this, it's available there. It's a Phosphor Myosin. Now I can tell you it's available in Bahrain, at least in my hospital only a month ago. Phosphor Myosin, this is a meta-analysis for above 1,600 articles, but eventually it's been shortlisted to 27 articles. And it shows the comparison between phosphomycin and other comparators like phosphomycin and quinolones, sulfa, beta-lactamines, and other antibiotics. If you look to the diamond, the red one, you will see that majority of the studies or the articles favor use of phosphomycin. Probably the quinolones is much better, is better than phosphomycin, but it should be reserved at least for those patients with resistance. Phosphomycin, the good about it, it's a single dose. One sachet, you drink it, preferably on empty stomach, and don't eat for 2 hours. And this will be concentrated in the urine for at least 3 to 4 hours and can follow the patient. It's been approved by the FDA, and it seems to be, it's been tested in the pregnancy, and I use it in pregnancy. It's safe. The other uncomplicated categories, which is the pyelonephritis, we have here systematic symptoms, chills, fever, and most important things, if this patient presented with pyelonephritis, we have to be careful there is no urological obstruction, because that, if we leave it, it will lead to urosepsis. And we have to do the ultrasound to rule out obstruction. Sometimes we might do CT or excretory urogram for a sick patient or patient who is not responding to antibiotics after 72 hours. This study shows the comparison of ciprofloxacin with Septrin or Bactrim. It shows that here, if you look to only the red, what is written in red, we are studying the clinical cure and the bacterial eradication for Septrin on one side and the trimethoprim sulfamethoxazole on the other side. And there is superiority here, evidence superiority of ciprofloxacins on top of sulfa. If the patient is sick, need admission and need broad spectrum antibiotic and IV parenteral. What is the complicated UTI? Basically, it is uncomplicated. All the uncomplicated are complicated UTI. And it's complicated even if you're dealing with uncomplicated UTI and your clinical judgment that the patient is too sick, you should consider it as complicated. All women with the UTI, having a complicated UTI, pregnant woman, or any urological abnormalities or comorbidities with the UTI. Diabetes, immune suppression is so common, obstruction is so common, and the most common things is you find, apart from the obstructions, probably foreign bodies, males, diabetes, maybe recent instrumentizations, okay? And E. coli still is the major agent. It can be local, like lower urinary tract symptoms, or it can be systematic. Cultures, it can be positive for 10 power of 5 or 10 power of 4. But in the management, we have to be very careful how to start the medications. First of all, you rule out any urological anomalies, assess the severities, and according to your practice, how much the resistance is there, because sometimes we need to start here an empirical therapy. And the empirical therapy, after taking the culture, should be based on your experience, local experience, and basically because a lot of microorganism resistance to the antibiotic, our choice should be careful. Still 40% of the microorganisms, common microorganisms, are resistant to our common use of antibiotics. So, what is the best choice to use empirical therapy? Should we use a single or more than one antibiotics? Here, it's a huge study from Netherlands, and showing, if you see the green, the blue on top, it's all microorganism, the gram-negative, gram-positive. While the yellow, it shows the more serious one, the gram-negative UTI, and different antibiotics. If you look at them, it is a very busy slide, but the second slide will explain it. If we take, for instance, to start an antibiotics, we will say anything less than 5%, we can use it safely for empirical. And here the 4 drugs. And then if we include the negative as well, then we really either we choose the 3rd generation cephalosporin with gentamicin or penicillin with gentamicin, as the best is we use carbapenem. Sick patient should be admitted to the hospital. Probably I might stop here if you want, because okay. Oh, it's already come, thank you. Anyway, it's only the remaining is the recurrent UTI, which is the same as the UTIs, but we have to be careful and we have to work on them carefully. And prophylaxis is more important. Lifestyle changes for the UTI, especially in a female, using of some vaccines, or some people, they give either continuous antibiotic low dose or post-coital, or self-diagnose and self-treatment. Thank you so much.